Dr. J.K. Reddy is again a very eminent speaker. He's there in almost all the important forum. He's the group head for Cataract and Cornea at Shankarai Foundation, Coimbatore. He will be talking to us in the management of post-cataract pain and inflammation. I think a very important topic because one of the most common performed surgeries remains cataract surgery, and also one of the most important cause of treatable blindness in our country is cataract. So when we are expecting patients to do really well and they turn up with pain and inflammation, I think it's an important topic. Dr. Reddy will be covering that. Over to you, sir.
Thank you, Dr. Chitra, for this opportunity. And this is looks like in these talks, going through these talks, it looks like a more or less like a sponsor's talk, a slot given for the sponsor when compared with the other talks. This is a cataract, and what is the importance of it? The cataract nowadays, you see this surgery, it looks so amazing, especially when we are doing, experts doing, or most of the people, it looks so atraumatic and so nice, and it finishes within few minutes. The main question is why there is a pain and inflammation cataract surgery. Why should it occur at all? It should be a painless and no inflammation surgery. And another important thing is for pain and inflammation for trauma or post-surgical, the commonest drugs used across in human body or in animals, anywhere on the living creatures, are prostaglandin inhibitors, not steroids. Steroids are very, very rarely used for controlling pain. Why we are using steroids in this particular category to control pain and inflammation? These are the two big questions for me for past 20 years, trying to find the answer. Now the research works by a small group, by a group. It shows that the inflammation is from lens epithelial cells. It's not the surgery. It's not the ultrasound from the probe or the iris manipulation, something like that, because in phaco you don't touch the iris at all. So it is inflammation from the lens epithelial cells. It starts a few hours of surgery, goes up to 10 to 15 days, COX-2 levels, then it stops. That is the critical period. So the pathway is a good old side with the pathway. The steroids blocks much earlier. It should block the cyclooxygenase, but somehow they escape. How they escape, why they escape also, it's a small question. How they escape and why we need anti-inflammatory drugs, NSAIDs. The choice of anti-inflammatory drugs now we have in cataract surgery. In general, they are NSAIDs, non-steroid anti-inflammatory drugs, prostaglandin inhibitors. But in ophthalmology, peculiar to the cataract, we do have steroids as the mainstay. So the present practice pattern is steroids topical, main choice, and prostaglandin adjuvants, and oral or cycloplegic. So topical, what are these prostaglandin agents? They are approved for one, and the evolution, if you look at, it started with a ibuprofen, just a systemic one as a topical preparation, and it progressed slowly to nepafenac, which is now launched as a 0.3%, which is quite efficacious. So the inhibitors of prostaglandin, since anti-inflammatory, they have unique property of analgesia, whereas steroids has no analgesic effect. So steroids cannot control pain. That is the main important thing in this one we need to keep in mind. So the other thing is postoperative pain, macular edema, and mydriasis. So where they differ from steroids is the depth of penetration of topical application. Steroids maximum goes up to the iris. They can't even reach the ciliary body, whereas the prostaglandin, especially nepafenac, reaches every part of the eye, and profound analgesic action and mechanism of action of COX inhibitors. So in combination with the topical steroids is a routine practice. Their synergistic effect, and the post-op it controls very well than steroids alone, because steroids has no analgesic effect to control inflammation. If you look at the studies, there are very, very few to say that NSAIDs alone versus corticosteroids. There are studies which were searching and found few studies. NSAIDs alone in cataract surgery without steroids, and they are in favor of NSAIDs alone, though it's not a common practice. NSAIDs and corticosteroids are the common practice in cataract surgery, post cataract surgery controlling inflammation. So nepafenac is a potent molecule, 0.3% with the BAK. This is very important. We need to understand this will be converted to amphenac. The BAK is very essential for penetration of the drugs. Without BAK, there are smart people, they want to put smart steroids, smart preservatives, but the problem is it doesn't work. It won't go for bioavailability of the drug. It will be chemical equivalence, but bioavailability and therapeutic equivalence will not be reached without BAK. The dosage is very simple, apart from little expensive drug, and it's once a day. It's a fantastic for the patients or for the attenders. So the life is much easier for post-operative management of these patients. The addition of Vargam is also a lubricant, so you avoid the lubricants and you can have a saving of money for the patients in that. The aqueous concentration and availability is quite good when you look under the curve, and it's when compared with other uh, NSAIDs, it's fantastic. So it's a well tolerated drug and very low incidence of side effects, and it goes to all codes of that. That's very important compared with topical steroids. Topical steroids cannot go beyond the iris, whereas this one has proven 0.3% of phenolic. It reaches all parts, including the choroid and macula, at significant therapeutic concentration and stays there for a long time with single application. So what are the adverse effects we need to remember? Epithelial toxicity, dull and ulceration, yes, they do happen, especially in dry eye patients. Or if there is a pterygium or a large pincula or leg ophthalmos, these cases we have to remember should be careful. And delayed epithelial defects, if there is epithelial defects, and allergic dermatitis, it's occasional, but it does happen once in a while. In conclusion, topical steroids with NSAIDs are very must for controlling pain of intraocular and give a better patient comfort and compliance. In complicated cases, the prolonged use of topical NSAIDs, it reduces the morbidity to a significant degree when compared with steroids. So this is an epiphenolic is only drug when it's compared with other drugs, which is a prodrug, and it's got analgesic effect even with a prodrug effect. And amphephenic converter, it's a very powerful analgesic effect and reaches the posterior segment of that. It's very important. All the ocular tissues are reached, and it's well tolerated with a low incidence, and compliance is very good. The question comes here: can NSAIDs replace steroids? My answer is, after long, prolonged 10 years of working here and there, working on this, my answer is yes. The advantage is less fear of infection, less chance of IOP, especially myopia, no rebound inflammation after stopping steroids. Steroid dependence is, this is in my wish list for more than 2 decades. I started a year back. This is my schedule. Epiphenolic 0.3%, 3 times a day, 10 days, 2 times, 15 months, but still I'm continuing for 6 weeks. I didn't reduce, and homoatropine for 10 days. This is my typical post-discharge summary of patient. They just receive an epiphenolic and homide drops, and 3 times and 2 times, and no lubricants, no antibiotics, no other drug, no steroids. So it's a 1 year follow-up. Almost all cases, maybe 1%, less than 1%, they receive steroids where there is some additional complications or perioperative complications. The advantages I got is very less rebound inflammation. It's very, very rare to see a patient to come back to you with pain after stopping the drops. Very unusual, almost nil. And the simple dosage and better compliance and better confidence. Patient becomes very confident when you give such a small drug. They think you are done an excellent surgery, so you are not giving too many drops to apply. So that increases patient confidence, and they're really opting for the other. And photophobia. This is very important finding I found. This is photophobia, intolerance to light. They say whether it's intolerance means it's a photophobia or it's a glare. This is very difficult to diagnose. That's very less with this combination, with this drug. Then this is a very unusual, but it's not unusual, to be frank. When you do especially bilateral surgery and give 6 times topical steroids, the steroid-induced psychosis to a mild degree. The first is insomnia. The patients, 10% of patients, they do complain. They are not able to sleep well after surgery. Before that, they are reasonably fine. Then the remaining things, confusion, euphoria, irritability, they are there to some extent. I am not well. I am not that well, feeling tired. These are very common complaints, which almost vanished in my patients after stopping steroids. This is time for change, I believe. And what is the problem? The fear. What happens? The fear is only holding the people back. The fear is, as rightly pointed by one of the intellectuals, they say it's destructive, it's not constructive. Why humans have a fear? It's no intellectual will accept people Fear is a constructive thing. They all describe it as destructive, and they all suggest to get out of the fear. So this is aptly given by David Apple, very nicely framed, and his fight for sight. Harold Ridley and his fight for sight. He changed the world so that we may see better, see it. The entire world, especially the elderly people, population, which are going for cataract surgery. He has to so much fight for sight, but we are peace-loving people. We don't want to fight. We want to stick out to traditions. I think slowly we will move step by step. We make the lives of the people a little bit add to their comfort. Thank you very much for this opportunity.